Good afternoon, everybody, and welcome to the SEMPQIC Coalition meeting. I'm Vern Anthony, lead consultant. The rest of our team is also here. Alethea Carr, I think everybody knows Alethea very well. Lisa from GDAC, Lisa Braddix. Iris Taylor. Hi, Iris, another one of our co-hosts. Jen Torres from MPHI. Karen Schrock, wave Karen, who's heading up our Merck for Mothers project. Andrell Sturdivant, who's doing our community work, helping us out with that. Of course, Devin is always faithful and on time, because if she's not on time, nobody's on time. Handling everything behind the scenes. And I think I got everybody. I do want to introduce a new team member, Dana Harvey, who Dana's going to be helping us out with communications. So you'll be hearing from her a little bit later. So welcome, everyone. We're really pleased to have you here today. This is such a time of change, a time of turmoil, a time of opportunity. So we're right at the crux of something new, and we're hoping we are going to make it, not just something new, but something better. And SEMPQIC has a huge role in that. And you all, by coming and being a part of SEMPQIC, also have a huge role in that, both collectively as well as individuals. So I guess we can say the best of times, the worst of times. You know, sometimes we have to step back a little bit from the news, stay woke, but stepping back a little bit from the news so we can see where we are, what we've done, and clear focus on where we're headed. So with that, it's about almost 5 minutes after 1. And we're going to start the meeting unless anybody else on the team has something. Be sure to sign in on chat. If you have any questions, please put them on chat. And we make sure to answer every question that's out there. If we have time for questions from the floor or from the audience, we may do that from time to time. But please don't hesitate to ask questions or offer comments or suggestions. We do study the chat list very closely when the meetings are over. So with that, I think that covers all the housekeeping. The agenda is before you, and at the end of the agenda, after your breakout sessions, we're going to have Kate Cohen-Perry, the president and CEO of GDAC, the CEO of GDAC, and Renee Branch Kennedy, the CEO of MPHI, to bring you up to date on the integration and or some people call it merger, but the joining and partnership between GDAC and MPHI. That's very, very important. So that will be the last thing on our agenda, but we're going to start out with Dawn Shanafelt, who's also a member of our SEMPQIC team, to give us an update on COVID as well as infant mortality. Dawn?
Thank you so much, Fern. Thank you so much. So everyone, I would like to start off by saying that I'm going to share an overview on where specific data sources can be found. But importantly, I want to take a moment as we go through the slides to reflect on the successes that we've achieved as a SEMPQIC body and membership, because I think that's really important. And then collectively, all of us in the maternal child health space. So next slide, please. So as mentioned, I'm going to go over some COVID-19 updates related to the MCH population, as well as share the location of where you can find some additional Michigan COVID data specific to Region 10, so Wayne, Oakland, and Macomb counties. Then move into 2019 infant health data, and that's just going to be kind of a brief overview, important overview. But and I will also share information about the fact that SEMPQIC will be hosting a data meeting, so we can dive in further into the data and talk with our maternal child health epidemiologists. And then, as always, I'm open to any questions and answers during today's meeting or after, and I'll share my contact information. Next slide, Devin. So highlights that I want to go over are a recent Journal of the American Medical Association publication, a recent CDC report that was released yesterday, and then also talk about some concerns that have been shared about birthing care team access with patients and what the status of that is, given that we're in a different time when it comes to our COVID-19 data in Michigan. Next slide, please. So again, I want to start off by bringing your attention or calling your attention to this latest journal article that was published by the Journal of the American Medical Association. My slides will be shared, and these are all links. You can delve in further. But as we've known for some time, but now we have the data to really call our attention to these concerns. Women with a COVID-19 type diagnosis have higher cesarean delivery rates, and that's reflected in their higher pregnancy complications. So pregnancy complications such as induced hypertension, preeclampsia and eclampsia and infections. Moms who have been diagnosed with COVID-19 have a higher ICU admission rate, both for themselves and then also for their babies, have a higher preterm birth percentage. And then 12.9% of the infants whose moms tested positive for COVID-19 have tested positive for COVID-19 following birth. So these are all important indicators to look at as we move forward with the vaccine promotion and families making the informed decision about being vaccinated. Next slide, please. I mentioned a release of a CDC report. So that report was released in the New England Journal of Medicine and was shared broadly yesterday. So additional findings regarding the vaccine and vaccine safety for pregnant women, as well as information about where you can see COVID-19 data, particularly related to pregnant women. As I shared in our previous meeting, Michigan is part of a cohort of states that are submitting data regarding women who contract COVID-19 while pregnant, as well as the subsequent health and well-being of their infants. And so this is just a snippet or a screenshot that I've shared here. And again, these are all links so you can delve in further. But I want to point out though that you can go down even further to the state of Michigan and see the specifics, as well as the number of pregnant women, whether or not they've given birth, what their birth outcomes are, and specific demographics. So I think that's all important information that we all should be monitoring closely, being part of the maternal child health world, and the fact that we serve families, and then also for the families that are part of today's meeting. Next slide. I want to point out too that all this data and our discussion is extremely important, but for the sake of time, I'm moving through rather quickly. So don't think that my briskness is related to this not being important. It most definitely is. So our SEMPQIC leadership team asked us to pull together and share the data specific to Wayne, Oakland, and Macomb, so your Region 10 area. And I wanted to share that if you visit our michigan.gov/coronavirus website, and you scroll on down to where the Michigan map is that shows all the counties of Michigan and what the current COVID-19 case rate numbers are. You can click on cumulative data or to delve further, and you can pull up data based on counties and look at a variety of different indicators. So this is cumulative data that you're seeing here for Wayne County and its cases that are in blue. And you can see that the cases, and this is important, you've seen this in the not only Michigan news or local national news, but we're seeing a rise in case rates in the younger population. So I want to point that out here. So these are cases, and you can see they're per thousands, and look at how high the case numbers are in Wayne County for young people 20 to 29 years of age. So I want to just point that out too, and then also share specifically information, you can see per million age groups as well too, and you'll see that that younger age group is higher, which most definitely is part of the reason that vaccine availability has been opened up for 16 and above in our state and in our country. There's breakdown also by race, by ethnicity. You can delve further into looking at testing and the next slide, Devin, please, shows the database for deaths. And so you see that this is in red, but I want to draw your attention to right here. Do you remember a moment ago, I showed you the case rate numbers and talked about the 20 to 29, and that bar was really high. You can see the difference in deaths in Wayne County. That was our older population. And thankfully, due to increased vaccine numbers, the number of deaths have come down. And that's in conjunction also with what we've learned medically about how to treat patients who have COVID-19, how to respond quickly, how to mitigate symptoms, and most importantly, how to prevent death. Next slide, and I'm going to move through these somewhat quickly. This is Macomb and case numbers. So again, case numbers are in blue, the death numbers are in red. And again, you can see the variation, but notice when you look at Macomb County, you don't see the as high a spike in the 20 to 29-year-olds. It seems to be somewhat level. Been very concerning, but also somewhat level. So I just want to point that out. And then but when you look by per million, again, it's level as well, with 20 to 29 being higher. Next slide, please. And again, we see the very concerning numbers of deaths that happened early on. They're still happening, so I don't want to minimize that, but early on when COVID-19 hit the state of Michigan over a year ago, and we saw that just skyrocketing numbers of deaths that happened in our older populations. We're extremely concerned. This is Oakland. Notice Oakland, very similar to Macomb. See how this is more flat through here versus, and the same for whether it's by age group or cases per million. So I just wanted to point that out as well too. There is some differentiation between Wayne, Oakland, and Macomb. And I would venture to say if we delve in further and looked at like the city of Pontiac and the city of Detroit, Hamtramck, you'd see very different variations as well. Next slide, please. Again, very similar to Wayne, Oakland, and Macomb. You're seeing the number of deaths and seeing where that where those numbers fall as well too. Again, also broken down by race, by ethnicity, age, identified gender. So again, if you visit coronavirus or michigan.gov/coronavirus, you can see that the specific data indicators that I mentioned and delve in further and look much closer at your various communities. Next slide, please. And now we're going to transition.
Excuse me, Dawn.
Yeah, absolutely.
Do you want to say anything about vaccines before you transition to infant mortality?
Yes, I certainly do.
Yeah,
absolutely. Quick. Yep, absolutely. So as of yesterday, or actually the 23rd, the state of Michigan announced that that we would be resuming the use of the Johnson & Johnson one-shot vaccine in the state, as well as many of the locations where residents can get the vaccine are now no longer appointment-based. They're drive up, walk in, which I think is really, really important, extended hours, just a host of things that are happening. But we are seeing, and Vern can speak to this, given her role in advising the state, in vaccine hesitancy. So a decrease in individuals seeking the vaccine. So initially there was an extremely high demand, and there's still demand, but it's waning, and that's concerning. It's been reported that we have a decreased number of individuals getting fully vaccinated. So getting, if they have 2 shots, they're getting Pfizer and Moderna, getting 1 shot versus 2. Concern about what the pause in Johnson & Johnson vaccine may have potentially done. In reality, it was a cautious pause to make certain that there weren't concerns with the vaccine, which is a good thing. But again, there's been some challenges for a variety of reasons. And I think we need to acknowledge the historical trauma and how that plays into individuals seeking vaccine, but as well as ease of access. So with that, Vern and Iris, Iris definitely at the front lines with the Detroit Health Department. Chime in.
We'll be talking more about that later. And I was gonna mention that Iris is on the call, one of our team members, who's also managing the vaccine sites in Detroit. Somebody put on the chat that there's a rumor that many hospitalized people have been vaccinated. And she would like, this is from Christy Stasinski, some evidence to dispel the rumor. So maybe we can follow up with that, because that is indeed a rumor. The people that are hospitalized, except in very rare exceptions, have been vaccinated, have not been vaccinated. Mm-hmm. And those who have died have not been vaccinated. So.
And Dr. Daly responded in the chat as well, that she's heard just the opposite, 100%
right.
people.
Thank you, Dr. Daly. Yeah. Okay, I don't know if Iris has any comment, but I would say that pretty much access is no longer a problem, at least as far as having community sites is concerned in Detroit.
That is absolutely true, Vern. There are 10 to 12 or 13 sites that run every Saturday. We have sites that are open till 7 p.m. That are constant Monday through Friday. We have the drive-in downtown at TCF. We have a drive-in the neighborhood on Grand River at Straight Gate Church. So access is not an issue. We're everywhere. Yeah. And we're at individual churches and community-based organizations who just have a smaller crowd of their own constituents that they want us to serve. We also go to them as well. So access is clearly not an issue in the city of Detroit.
Right, and much work ahead of us. You want to move to infant mortality, Dawn? Thanks.
Absolutely. So thanks for that, Vern and Iris. Next, I want to move us toward, I'm going to share a bit of the recently released, and there's a press release that went out this morning from the department regarding the 2019 infant mortality or infant health data. As I mentioned in the beginning, I'm just going to show brief information because your SEMPQIC leadership team will be hosting a data meeting coming up later on this summer. So with that though, I again want to encourage us all to take a moment to celebrate as well too, because there definitely warrants celebration in what I'm going to be sharing here today. It doesn't mean that we don't have much work to do. I'm not saying that at all, but definitely it's cause to pause for a moment for celebration. So in 2019 for the state of Michigan, you'll see our infant mortality rates here on this slide ranging from 2010 through 2019. Know that our 2019 infant mortality rate of 6.4 is the lowest that we have on record in the state of Michigan. Our records go back to 1970. So again, I think that's something to absolutely celebrate. You've heard me say before that we like to look at the data for a longitudinal period for 3 to 5 years, which is definitely important because data rates are unstable from year to year, given the number of babies that are born changes. But most definitely, this is cause for celebration. We've never reached this number before in the state of Michigan.
We can take a second to applaud ourselves.
Absolutely. And with that, I would also just call our attention, which I always do, over here to the right. With the celebration in Michigan, we lost 695 babies before they could have their first birthday party. And I think we need to keep that in mind. That while we celebrate, this proves that we can bring the rates down. We need to bring them right on down to as low as we possibly can in our state. Next slide, please. And this looks a little bit blurry, and I'm not sure why. I apologize. I thought it was multiple colors, but it looks like it's not. I'm not sure what happened. So I apologize. But I want to point out, though, that the disparity, the Black-white disparity for infant mortality in 2019 has decreased. And I want to mention that as well too. So while the ratio goes up and down, we're seeing a downward trend. We were all, if you remember, we were sitting here actually in the room at GDAC, very concerned 2018 when we saw the numbers, if you look at moving right on up. Thankfully, in 2019, the ratio is beginning to come back down. And again, this information that's shared here is for the state of Michigan. Next slide, please. This slide shows the infant mortality rate for Prosperity Region 10. So for Wayne, Oakland, and Macomb. And again, we've seen an improvement from 2018 to 2019. So I want to highlight that as well. Granted that we have seen lower average during the or lower annual infant mortality rate for Wayne, Oakland, and Macomb in 2016. But again, we're coming back down again from a very concerning time in 2017 and 2018. So I just want to highlight that as well. Next slide, please. This is the infant mortality rate broken down by race and ethnicity. And again, you see the huge disparity that we have. This is Region 10. This is aggregate data, which I want to point out as well too on this slide. This is 2015 through 2019. So note that here, as well as the disparities that are seen for Hispanic families. And then again, I'll always call your attention to the number of infants that we've lost. And you can see that on the right-hand side of the screen, just under the third column, number of infant deaths. Next slide, please. You can see here depicted a stagnant low birth weight percentage. So I want to point that out here too as well. So we were staying right at 9 to 10. So 9.2 through 9.9 when it comes to the number of our babies that are born less than 5.5 pounds. Next slide. Again, the disparities that this team and those of us in Michigan and around the country are working to eliminate. You've all heard me say we should not have multiple bars. There should be one bar, this Michigan residents.
Well, it's 2 to 1 now, look, half.
And in a moment when I show the city of Detroit, we're definitely going to have a moment of clapping when it comes to the ratio. Next slide. This is preterm birth. Again, preterm birth and low birth weight are common characteristics of babies that don't live until their first birthday. And again, these preterm birth numbers are very, very stagnant as well too. Next slide, please. Again, the ratio here for preterm birth based on race and ethnicity. Next slide. And here's the pause for celebration. And I've had our EPIs check and recheck and double check to make sure this is correct. This is a 2019 overall infant mortality rate for the city of Detroit. It's 11 for a total of just over 9,000 babies that were born and 103 infant deaths in the city of Detroit in 2019.
This is huge.
Exactly.
Huge, huge news.
Extremely huge. And when you look
that decrease in infant mortality in the city of Detroit. Go ahead, Dawn. I just didn't want to slide past this.
No, absolutely. I mean, literally it should bring tears to people's eyes. And then when we look at the disparity, so we look at the number of white non-Hispanic babies, Black non-Hispanic babies, our disparity ratio is 1.27. Again, these are the lowest numbers on record for the city, and the earliest I could find city data was 1989. I said state data is 1970. So as we progress and evolve and change, thankfully we started breaking down our data, but the lowest that we have on record for the city of Detroit. And so again, it's cause for celebration because it means we can eradicate disparities. And it means we can drive down preventable deaths so that they're not occurring. And I know this is 1 year, but it's 1 year that we've never seen before. And it's hope that we can save more babies in the city and save these babies that are listed here too. The babies that died in 2019, or not save them, but save future babies.
Right.
I've asked our EPIs when our 2020 data will come out. The 2019 data was delayed due to COVID-19. So expect the 2020 data within the next couple months.
Go ahead to your next slide.
Next slide, please.
Yeah. One of the things that I want to bring out is that the high infant mortality rate in Detroit, Southeast Michigan, particularly Detroit, has been a major driver of the infant mortality rate for the state of Michigan. And we've always said, if you bring down Black infant mortality rate, you will bring down the rate in the state of Michigan. This data shows that to be the case, because the overall rate is down in the state of Michigan because, not solely, but significantly because of the improvement and progress in Southeast Michigan. So we all need to pat ourselves on the back and applaud, get another big deep breath as we looked at all the reasons why, and the EPIs haven't finished doing the peeling of the onion yet. So we can't say exactly what happened in 2019, what we did more of or less, because we don't have all that data yet. But SEMPQIC will be hosting a data summit, probably early in June. I don't know if Lisa's on, I don't know if we picked a date yet, but it will be in June. We'll have a lot more information around this by then. I, for example, really wanted to know what happened to low birth weight and preterm birth in 2019 and was surprised to see that it had leveled off. I mean, I thought, well, if we've had this big reduction, we must have had a big reduction in preterm birth, but we didn't. So of all the indicators that we might want to look at, and some of those indicators are probably outside of public health data, actually. But between now and June, the EPIs in the state of Michigan, we really will be tearing all this data apart. So come with your questions. If you have questions now, please share them with us and we'll put them on the table because we really want to know what we did really good and where we need to make more progress. You know, was it teen births? Was it unintended pregnancies? Was it sleep-related deaths? We don't have the numbers yet for sleep-related deaths in 2019, but we know that was a big driver of the high infant mortality rate. So the preterm data, someone asked that, is on the chart, on the slides that Dawn just showed. And you will have all these slides after the meeting. You don't have them right now, but you will have them after the meeting. And it does show the preterm birth data. So we're really excited and pleased to see that we have made progress. And I'm going to give all of us credit, everybody on this call who's been working, you know, in this struggle with this issue. We just have to make sure it's a trend and not a blip, although we know 2020 is going to be probably an aberration anyway because of COVID. But let's say thank you to ourselves and find out more information and really get focused as we go forward. Anything, Dawn, anything else you want to add, or anybody else on the SEMPQIC team?
I don't know if you have time for a couple of questions real quick, Dawn, but one was, do you know the 2018 infant mortality rate as comparison? And the other question was, does this capture deliveries in Detroit, but not citizens of Detroit who deliver outside of the city?
So to answer the first question, Alethea, these are residents of the city of Detroit. So that it's based on mom and baby's address. So it is residents of the city. And I do have 2018, and I'm going to pull that up. And while I'm doing that, I just want to mention too that, to Vern's point, I think that our collective effort as a state has definitely helped contribute to what we're seeing. And with that, I want to point out the Maternal Infant Health Summit, which is a place where we all come together and we address root cause, which is systemic racism. So know that registration's open for the summit. There's excellent speakers going to be there again. And in typical summit fashion, again, we're addressing root cause. We're not glossing over, mincing words, anything like that. We need to be in the trenches together to save lives. So with that, I'm going to pull up, and I apologize, but I do have the rates for the city of Detroit going back to 1989.
Maybe you can just put it in the chat. Thanks a
Yeah,
lot.
perfect. Yep. Next slide, please. I think this is my last one. And then here's my contact information. Always feel free to reach out to me. Call me, text me, send me an email.
Thank you, Dawn.
everyone. Thank you.
Thank you, Dawn. And we're, again, real excited. The press release went out today, so hopefully we'll get some coverage on something good tomorrow, if not later today, as it relates to the city of Detroit and our work. And a lot of this information is available on the website, MDHHS data website, right? Dawn?
Yes, it sure is. So michigan.gov/MCHEPI, and you can see all the data for each of the regions. And I will put that in the chat as well too here.
Okay. All right, moving right along. Iris, do you want to introduce Cherie?
Yes, it is my pleasure to do so. As we are all committed and struggle with the ideas of how do we create community immunity? How do we encourage individuals to receive the vaccine? Then it becomes the question of whether or not you can entice someone. Can you pay someone? What do we do to encourage people to assert what is their civic duty anyway? So during that as a conversation, I had the opportunity to meet this person who seems to be very outstanding in her field. She is a nurse practitioner, a graduate of Loyola University of Chicago with a master's in bioethics and health policy ethics, and a doctorate in bioethics. She's currently the director of ethics and integration at Ascension of Michigan. So please join me in a welcoming of Cherie Sammis.
Thank you very much. And I want to say hello real quickly on my video before I stop it, because everything is freezing here. So if for some reason I drop off, I will join back in. So kind of bear with me. Next slide, please. And I was asked to give this presentation in about 15 minutes. And I very quickly, I perused the 93, 94 names on here. My colleagues, Cynthia Tagg and Karen Sheffield and Tashara and Maria Gibbons and Renee Kennedy know me, I think, fairly well. And I don't say hello to a paper bag in 15 minutes. So this is going to be a real stretch for me. And as you know, vaccine ethics, of which I'm very passionate about, there's so much out there. I could talk for days and hours, but very privileged to be part of this group. And I would be remiss, as someone who's been involved in maternal child and infant mortality since I became a nurse almost 42 years ago. I am in awe at these numbers. And I hope you publish far and wide. It gives all of us hope for the future. And infant mortality rates is, as you know, it's overall health for all of our community. So job well done. I don't even know how I can follow that. What I'm going to do is very briefly, there's my contact information. Next slide, please. I'm going to zip through these pretty quickly. And then I believe we're going to share these slides for you all at a later time, if not already. I want you to take a look at this. This is a good ethicist. This is after 2 graduate degrees and several certifications and a doctorate. If you do it right, part of the people in this group are going to disagree. Part of the group will agree with me. And out of all the recommendations, there's yes, no, maybe, and maybe yes, and maybe no. So my husband gave me this cartoon after I finished my doctorate for what he said cost me a gazillion dollars. But if you do it right, there's a range of options and recommendations. But I must admit my bias, I'm very pro-vaccine. And I think there's an argument to be made for limited incentives. So I'll start and end with that. Next slide. So the next two slides, and you can read along with me, I'll try to speed read here, but I think it's very important because each one of these dot points could literally be a conversation for 30 minutes or an hour. So when you think about the ethics of vaccines, let alone the focused conversation of ethics in incentives, think about what you all have experienced even before COVID came to be, and the COVID vaccine when it rolled out back in, oh my goodness, December and January. Equity of distribution, prioritization for vulnerable groups, and how and who and what defines what's a vulnerable group and who's on first. Those most affected, persons of color, should those with disabilities jump up? Should the economic and socially most deprived jump up above those? What about our unhoused, AKA homeless populations? What about the elderly, homebound, those most needed for prioritization to serve others, healthcare workers? What about the single, healthy, white, young mother, but she has a child with Down syndrome? Does she come before or after the dentist? And we all know what we've been trying to do for barriers to access. And it was a different conversation back in December and January to where we are today in April. And I'm reading in the chats, walk-up clinics, walk-up clinics. We're at a tipping point, I think, which is good, but also, quite frankly, gives me a little bit of pause. The organizational processes that we've been trying to develop also have affected disproportionately, both negatively in some way, maybe a little bit positively in another, our undocumented and or our immigrant populations. I know you all saw recently the memo that came out from HHS, Figueroa finally. There's a wonderful patient fact sheet and a provider fact sheet as it relates to persons who may be undocumented and without papers, that although in these vaccine clinics, we may be asking for identification, maybe even asking for an insurance card, it's not to be a mandate. So I think there's been a swing in that. So I'm very hopeful that our migrant populations and those undocumented will actually come forward and receive the vaccine. When you think about this insurance card that we all started with, an ID, it actually created fear and avoidance. And quite frankly, I'm going to provoke you all. We have a lot to clean up to get where we need to be. Next slide. When you think about resource allocation, it's not just the vaccines themselves or the locations you're actually doing it, but think about the human capital utilization and the people. And I'm sure many people that are on this conference today maybe have been redeployed to focus on COVID, all hands on deck. And what has happened as a result of that in competing, in trying to address other health issues that maybe had to be put at the bottom of that prioritization. When you think about incentivizing, is it for encouragement or is it for coercion? I want you all to think about that yourselves. And maybe I'm hoping to provoke a little moral distress. How do we manage both vaccine hesitancy and vaccine resistance? Two different concepts that I know you all already understand. But again, I think we're at a crossroads this week and this month. When you think about the legal implications of both incentives and otherwise, there's legal implications, but sometimes those legal implications may or not line up with the ethics implications. There are potentially in the future some vaccine mandates you've seen on the news. Perhaps there may be mandates in the near future for some healthcare workers. And will that become higher than some of our other service industries? And who counts as the definition of essential worker for possibly in the future a mandate? You can go to each state government website and read the definition of who counts for an essential worker. And it's mind-boggling because it's quite variable. There are restrictions when you think about for those that we may be imposing upon others in the near future, for those that choose or otherwise are not vaccinated. Will those restrictions become unfair or punitive for religious or those that have medical exemptions? I classify them as exemptors. And when you think about the intrusion on individual freedoms, privacy, you know, people are talking about having vaccine badges. Well, what about the people that can't take a vaccine and therefore might be marginalized themselves? And when you think about pandemic ethics, we change from individual rights to the rights for the common good of the whole. Next slide. So the next several slides, I'm going to focus in on what's called the ethics of vaccine just incentives. And as a background, I want you to think that we all have a moral duty as persons to actually participate in vaccines, right? Foundational. We have a duty to promote our own personal health as individuals. We also have a duty to others, being just a good neighbor. Becoming vaccinated for COVID and all those others, it's an act of charity for others. We also have a duty to society as a whole, for individuals, for each one of us collectively and individually to contribute to mitigating the effects of this horrendous pandemic. Those that may be in probable disagreement, some say that non-coercive measures are actually ethically preferable, AKA incentives, versus more coercive measures, meaning mandates. Some argue, though, that whether any incentive at all, no matter how de minimis, is actually justifiable because of the moral obligation that they should do. Some argue that payment itself is an affront to the moral code. Some argue that payment actually robs the moral imperative. Next slide. I know several of you already know this, but you know this principle of least restrictive alternatives in public health. So what we try to do is we try to have the least intrusion on a person's personal rights and freedoms, and whatever incentive, it should not infringe or abuse another's rights and freedoms. It should be the lowest degree of coerciveness, what I really prefer to call a sphere of influence, and keep it that way to get the maximum goal of immunization. An incentive should never be big enough to have the offer be so irresistible to refuse. When you think about global health policy and global COVID vaccine, this is one where this could be very problematic in the near future. We also have to recognize the current, I know it's going to change, but the current context of the vaccine fast tracking, it was done with high rigor in scientific evidence, but remember, it's still under an emergency use authorization. So that does create more uncertainty for side effects and weakens the case for vaccine mandates in the future. If that EUA drops off, then I could see it evolving. And payment in and of itself, in whatever form or fashion, may be unfairly taking advantage of those who during this pandemic have lost their jobs, have food or housing insecurity, maybe for the first time, and have fallen into desperate poverty just because of the pandemic. And this would really possibly be an unfair advantage. Next slide. Payment for risk is an important thought. This is where there's pros to incentives. Payment for risk has the advantage that the people that are actually choosing, it's voluntary to receive that vaccine, they are taking it on to vaccinate. This payment for risk, it is voluntary. So if there's accurate risk, then the benefits, each individual person themselves will actually figure out, well, is it actually worth that incentive to get in my car and drive, or have somebody pay for my transportation to get there, or to give me a gift card or a fruit basket raffle, or maybe several $100s, or maybe $1,000. So the key behind all of this is informed, transparent communication. I know you know this, but I need to emphasize this again and again. It's about informing in communication and education and awareness to lift up all persons equally and with equity to make their own decisions and how to build trust. Next slide. Did any of the, okay, try clicking again. Let's see if any of those pop up. Or did it, oh, there we go. All right, look at this. This is incentives across the spectrum. We're beginning to compensate hourly workers to go get their vaccine. We're covering time off from side effects instead of having to use your own vacation time. Lyft is providing reimbursement for Target employees. Our grocery store chains, Aldi and Kroger, Trader Joe's, Dollar General, they're paying up to 4 hours to have their persons vaccinated. Krispy Kreme is giving out a free donut. Budweiser, I saw it on the television, I couldn't believe it. You can go to a website, if you show your vaccine card, you get the first one on Bud. I put the, something to think of. I put the smiley face there. I like the Krispy Kreme donuts. I'm not a big drinker, but then those of us in public health and wellness, donuts and beer. Is that a perverse incentive or not? When you think about Houston Methodist Health System was one of the very first health systems in the United States that actually provided early on a $500 cash, what they called a hope bonus. Now they tried to weave this in for ethics to make it blend in with some measurements that they have to meet the bar for some quality measures and performance, in addition to if you got your COVID vaccine, and it was actually used as a tipping point. Some other systems have said, hey, we'll give you a 2% or 3% bump this year if you do these quality measures for improvement. And oh, by the way, you have to have the COVID vaccine to enter into the pool. Something to think about though is think about the broad spectrum of people that fall into these, and they could be unduly influenced. Think about entry-level staff that maybe get barely minimum wage, and maybe not so much for that specialty physician or anesthesiologist. So it's unequal for sure. Vermont, the government came out and they're offering $100 for anybody to come forward to vaccinate. Phoenix employees are being offered $75 in addition to time off. There's a nursing home in Pennsylvania that's giving $750 if you complete your vaccine series. The goal, they said, is because the death rates of frail elderly in their nursing homes and long-term care are so abominable, they said they've moved the bar, will do anything and everything it takes to try to save lives of frail elderly. And you know, there could be an argument for that, although I did raise my eyebrows when I read about that. So we have de minimis ones that are okay, raffles, maybe a TV raffle, gift card baskets. I just read from the Brookings Institute for Policy. They came out and I believe they put this forward for consideration as a federal policy. I don't think it'll go anywhere because we can't afford it, but to offer $2,000. You get $200 if you get your vaccines. And oh, by the way, we're going to give you $800 a little bit later. Interesting concept because we're really trying to get our nation healthy, but it could be a slippery slope. Next slide. So pearls of wisdom for good incentives. Incentivizing a person or groups of people for encouragement. Say, for example, to pay somebody a nominal fee to actually come or join a Zoom to actually learn and be educated for awareness. That could be ethically justifiable. Providing transportation that pay for time off, maybe even a child care voucher, right? Having those walk-in appointments that I read in the chat box. Several months ago, I would say to you, I'm going to poke the bear. Several months ago, we should have had places for walk-in appointments because I think we would have been able to achieve a little bit better in terms of vaccine distribution and equity. But we fast forward literally only 4 or 5 months and we're there, but something to think about. And then again, if you're going to pay cash, the nominal foundation shouldn't really be paying more than you normally would, for example, for jury duty. What we really should be doing is creating those welcoming environments of comfort, taking vaccines to their neighborhood with trusted partners and vaccine ambassadors. I call them pop-up equity clinics. Take the vaccine to them, take it into the home. I was in Maryland last week, and I drove by a neighborhood where they had the housing authority that partnered with the local city and state health departments. and they had people lined up social distancing for vaccines, and they were offering coloring books and a little bit of gift cards and box lunches to go on the other side in your waiting area. And it was a really impressive turnout, but it was a collaboration of partnerships. I call that sphere of influence of trusted partners. I don't call that coercion. Thinking about how you're doing consent forms, and I know we've got legal consent forms, they still bug me because sometimes the informed consent form is a legal document in legalese and not written in low literacy, basic 3rd and 5th grade understanding of reading and comprehension, which is what all informed consent processes should have. And I think we have a ways to go for that. It's getting better, but there should be improvement. And then again, what you all do every day, and that's gaining knowledge on how to bridge gaps and disparities and actually apply those to vaccines. Next slide. When you think about coercion payment models, some people believe that payment for risk is again better than that mandate, which would be the end all last step. Some people say, though, just like in research ethics, when we're trying to get all persons, right, to think about coming in for clinical trials, to violate that ethical requirement that research participation should be voluntary, that we should maintain the same and not do mandates for vaccines. And again, repeat, payment acceptance is voluntary. You don't have to take the cash, although I guess I would. Or is it actually exploitation? Is it what we call, what's said in ethics, a perverse incentive? Are we really trying to enforce and push undue influence with perhaps too much of an incentive on very vulnerable populations, and desperate people do desperate things? And is that really right and good and moral or not? It's a provocative question. And is payment for populations that are most adversely affected with COVID, such as our Black and Brown communities of color, and think about structural racism that exists even today in medicine and in research, although we're doing better because at least we're beginning to talk about it, is these payment models, is it actually perhaps a way to get over some of these initial concerns for vaccine hesitancy and maybe look at it almost like a reparation that some are actually beginning to do? I'm not sure. It's a provocative question for you all to sit with for a while. And how does economic inequality actually shape the poor health for those persons that are actually declining COVID vaccines? Next slide. When you think about, again, the ethics of incentives and those contra, it may actually cause more harm. For example, think about the social media. And we all know what's out there in what I call falsehoods, and what might happen with the social media in conflating these falsehoods, that if you actually have to get paid to get the vaccine, it can't be safe. So we might actually be causing more harm. And you also have to look at the vaccine strategies that you actually had in place long before COVID. It was very rare for us to have large incentives, and we might have had nominal or minimal ones. What we're doing and what we're thinking about now with COVID vaccine could be counterproductive and might cause more harm in the future. And of course, look what's happening right now. What would this payment look like when you think about what's happened with J&J? That payment incentive might actually overwhelm that current lack of confidence. And we already know it's an uphill battle with the J&J pause. It was the right pause. It was based on scientific evidence. We support having it get back out there. That said, and it was justified, it's another mountain that we have to crawl through and over. And where do incentives fall into that? Next slide. So ethically justifiable recommendations, I'm ending here. Think about research ethics and the clinical trials when we want to bring in all persons. A nominal incentive as reimbursement for time and a commitment to participate is okay. A higher incentive, maybe to complete a series, maybe, not is, but maybe ethically justifiable for greater gain for both persons and community, particularly these hard to reach, transient populations that are so affected by COVID. And just as we do and have done prenatal care visits, we've given incentives and gift cards and baskets and layettes. Each time you've come in for that visit, each time you finished, you come up with a healthy baby, and look what we've done. And so covering what I call these indirect costs may be okay. When you think about taking incentives outside of the United States health policy, and again, you're looking at global health policy, there may be stronger arguments for payment models. But the caveat is that it may set a very dangerous precedent that may affect other essential vaccines and future vaccine needs in the pandemic. So what we say in ethics is we may have already started on that slippery slope, and it becomes actualized into reality and very hard to back it up. But you saw the news last night, and it's out there. Look at India, which is just being decimated. Look at Brazil. And we in the United States are trying to reach out to our neighbors and brothers and sisters to help them. But I think there could be handwriting on the wall here in which way we may need to go. So if you think about the current, I call it the sluggish demand and the desire for the vaccine, does that actually move what we call the principle of balance to actually justify more desperate incentive measures? Maybe yes, maybe no. Next slide. So now, today, this week, that environmental context, are the stakes higher and therefore more justifiable to actually increase those incentives to expedite compliance and beat this terrible race of the variants? Uncertain. But think about what we do in our hospitals all over the United States. We have nursing incentives. We're desperate for staff in these surges. We pay more for weekend and night coverage and during holidays to compensate for that greater need. So greater pay, AKA a greater incentive, may be ethically justified when the push comes to shove to have basic adequate coverage for care for the greater good of our community as a whole. Next slide. So the future as it relates to COVID vaccine mandates, people are asking that question more and more. When you think about ethics in pandemics, there's a move towards common good of the community and not for the individual person. So I could see this evolution, just as we have over the last years moved towards flu vaccine mandates. I would bet you dinner that we will in the future be moving towards COVID vaccine mandates no differently. But you have to think about the ethics again of the principle of balance. The Society for Human Resource Management came out and said if the employer provides incentives, there's a question in the amount of incentives that will it cause an actual conflict with the American Disabilities Act? Interesting question. Equal Opportunity Employment has said the proposed wellness plan regulations that are out there, and all employers have all these wellness plans to incentivize, how they might have to limit to have minimal incentives to actually participate in that wellness plan because there's an actual conflict of interest. And then look what's happening recently in our universities and schools and admission requirements for a condition of employment. So we may not be able to mandate current employees to be vaccinated, but we can certainly say if you want to come work with X company, you have to come to the table already vaccinated for COVID. So I do think there's evolution to that. And I'm going to end with how, fast forward to next year, how might we manage the future with our physician and provider practices who have the habit, sometimes appropriately, sometimes inappropriately, discharging patients and families from their primary care practices for what is called non-compliance to the vaccine schedules. Well, I put discharge in quotes because we discharge people from the military. We don't discharge people from our office practices. So that's a whole other presentation I do. And I also want to put in here that if we start that slippery slope more so with COVID vaccine, if you don't get your vaccine, you can't come into my office and be cared for. We will see a shift in care that we've been working so hard to try to eliminate and reduce. and that is for our emergency departments to be the primary care office. And lastly, I'll say there's no such word as non-compliance in ethics, because everybody has a story on how and why they're not able to adhere to our care plan. So we should be very careful because words matter. Next slide. Apply the principle of balance, apply the rule of reasonableness. Breaking barriers to access is not the same as coercion and perverse incentives. And think about the fear. We must not only respect beliefs of persons, but engage them as personal commitments for the people you are trying to serve in our community. And please explore their preferences individually and don't stereotype, because we must honor the innate dignity of each person, seek to understand, and your virtues of humility and empathy are prerequisites for vaccine success. And I end there. Next slide. Thank you. I know I went over, I apologize.
Well, I would say thank you, Dr. Sammis. Excellent, excellent presentation. And as I've noticed on the chat, a lot to think about. This could have been an entire afternoon or all-day workshop. But like you said, yes, no, maybe no. But there seems to be a lot of space for the appropriate and right type of incentives. There's not a one size fits all. And I wish we had time to take questions. But what do you think about the state of Kentucky? So you're muted.
I said, Vern, I went, that's my comment these days. I sigh more, I reflect more, and I'm stepping back more because I could drive across each state in the United States. And you know what? We're all doing it a little bit differently, and it's okay, but I'm scratching my head. I was down in Maryland. I drove over to DC and they do it a little different. I drove another 20 minutes into Virginia and they do it a little different. Something to think about, right? We might get care in one state, live in another, but seeks our vaccines in yet another. So lots to think about. And I go back to that cartoon of yes, no, maybe no.
Well, this has been very, very, very helpful. And thank you so much.
My pleasure.
Very helpful. Iris Taylor, give us a quick few minutes update on My AIM.
Okay, My AIM, we can go to the next slide. The My AIM organization in the state of Michigan has become one out of 7 states since 2015 that have engaged in this quality improvement effort. Of course, the goal is to eliminate preventable maternal mortality and severe maternal morbidity and disparity. And the whole crust of My AIM is doing it with various partnerships of the providers with across the state of Michigan. Go to the next slide, Devin. The structure itself is mostly volunteers. It works through the vehicle of having a steering committee and an operational committee. And the data sources are managed through the Michigan Department of Health and Human Services and MHA. Go to the next slide. So what we know so far since 2011 to 2015, here are some of the morbidity rates that were in the state of Michigan. And after implementing the quality improvement bundles of My AIM for 2016 to 2018, you see the difference in the improvement. So actually it is self-evidence that if we engage in certain behaviors around hemorrhage and hypertension, that there is an obvious improvement in final outcomes. Next slide, please. So we know that the bundles for My AIM are severe hypertension and hemorrhage. And they've also included sepsis and recently a reduction of postpartum or peripartum racial and ethnic disparities as well to the focus. With each of those areas, they look at outcome measures, process measures, and structural measures. Next slide. So what does SEMPQIC have to do with all of this? SEMPQIC had in their commitment in the Maternal Infant Health Equity Plan. We also are a partner in looking at, particularly for Region 10, how the 23 hospitals, birthing hospitals that we have are engaged in implementing the bundles within MyAIM. So we have partnered with them at looking at Region 10 to see how we might facilitate all the hospitals to participate in the quality improvement criteria and within the MyAIM bundles. So we are focusing on 8 currently, and acknowledging all the impact of COVID-19, we're looking at how can we facilitate that commitment translates into the submitting of data for outcome and process information so that we can then measure the overall impacts of implementation of those bundles. You could go to the next slide, Devin. So our objective is to improve participation, that we provide data that would enable trending, that we drive down ultimately the impact on maternal morbidity, mortality, and disparity. And the added incentive is that we're able to then demonstrate that the new Joint Commission on Accreditation of Healthcare Organizations safety measures include standards that essentially are aligned with the MyAIM criteria bundles. And so that in doing one, you're also then accomplishing the others. So if we create crosswalks, we can then assist in such that the bundles will be implemented across all hospitals within Michigan, and in particularly Region 10, which is our concern. Next slide. So that's it. So essentially, we're working with 8 hospitals to begin to identify how we can support engagement or re-engagement and moving forward. And we're excited about what may potentially be the opportunities that we see in the future.
Okay, thank you, Iris. If you have any questions, please put them on the chat. And again, we really are encouraging all our hospitals in Southeast Michigan to participate in MyAIM. It works. We know it works, evidence-based, and we need to make some of the same progress in maternal mortality that we're beginning to make the progress on infant mortality. So thank you, Iris. Okay, moving on. Many of you may recall that when we did our survey last year, one of the areas that you felt was lacking in our community was more discussion and resources around issues of grief and loss as it relates to loss of our babies, loss of our mothers, and now also COVID. So in following up on your recommendation and looking at ways that we can be more helpful as a coalition, we've invited Mildred Johnson and Myrsha Clemens from the Detroit Health Department, welcome ladies, to talk about resources to help families cope with grief. You're on the FEMA team, right?
Yes.
Okay, I'm handing it over to you two. Thank you.
Okay, thank you so very much for giving us the opportunity to be here today and to share with you about FEMA and what we're going to do for our mothers and I'm going to call it new, stages. And stages stands for support through action, guidance, empathy, and self-awareness. So I'll be going through FEMA, what we do in FEMA, how we got to stages, and Marcia will take over after that. So once again, thank you for allowing us the opportunity to present to you today. I've been with the health department for about 40 years, and I've worked in various departments within the health department. And I have to tell you, the work that I'm doing now is so rewarding. When Dawn was talking earlier about the numbers went down in COVID-19, my heart was just so happy and just so excited that we are a part of that process to help those numbers go down in the city of Detroit. So today, I'll be talking to you about fetal infant mortality review. I will share some data from our case review team meetings. We'll be talking a little bit about present and contributing factors that may have caused the death of the baby. And we will share a couple of recommendations that the case review team crafted for our community action team. So when we think about FEMUR, we know that FEMUR is a multi-level national, state, and local public health process used to assess and improve community health and well-being of women, infants, and families. FEMUR identifies gaps in services. This is an evidence-based process designed to evaluate medical, non-medical, socioeconomic, and system-related factors and circumstances that may have contributed to the death of the baby. FEMUR establishes prevention strategies. FEMUR engages communities to take action with the aim of preventing similar deaths in the future. So why do we do FEMUR in Detroit? In 2018, there were 723 infant deaths in the state of Michigan. 158 of those deaths actually were Detroit babies. So once again, it was very refreshing to hear that the deaths have gone down from 158 in 2018 to 103, I believe she said, in 2019. That's very, very encouraging. So we're hoping that 2020 data is going to be going down as well. Our main goal in Detroit is to reduce the infant mortality in the city of Detroit. Our aim is to serve the community by using the tragic experience of parents that have lost their babies. And how do we do this? There are steps that we do. We do maternal interviewing, which I do that. We also have nurse case abstractors that have the clinical portion. We also have case review team meetings. We do that twice a month now. We used to do it once a month, but we do it twice a month now. Those recommendations that we craft in our case review team meetings are actually given to our community action team. So the maternal interview identify cases from death certificates received from Wayne County Clerk's office, and also we receive electronically death certificates from the state of Michigan every Monday now. And because of the large number of deaths that's in the city of Detroit, infant death, we are only allowed to do so many through our grant funding. So we do 24 with a maternal interview. And this year we would do about 45 or 50 without a maternal interview. So we will actually review about 70 cases this year for our infant mortality. And we wanted to do more than the 24 so that we could do more data based on that. So we're going to talk about that a little bit too. So when we talk about our maternal interview, there are several things that we look at. We look at safe sleep-related death. We look at preterm birth. We look at birth defects. We look at maternal pregnancy, accidents, and we've even done case reviews on homicides in the city of Detroit. And of course, the biggest factor that we look at is the parents' willingness to conduct interview and talk about the death of their baby. And so during the maternal interviews, I found out that a lot of parents just do not want to talk about the death of their babies. And we do offer an incentive, but incentives all the time doesn't get someone to talk about what really happened to my baby. No one want to talk about, well, the baby was in the bed with me and I rolled over on the baby. Or, you know, there was something going on with my body. The doctor didn't talk to me about all the issues that I had. And Marcia will talk a little bit about being a self-advocate for yourself as well. And so the mothers don't understand why they had this preterm baby at 20 weeks. And so they don't want to talk about it. And so they would just simply, when we reach out to them, they would just simply say, no, I'm not interested in talking. Just on yesterday, I thought it was very interesting. I had written a letter to a participant back in November to invite her to be a part of this process. The girl called me early yesterday morning, and I'm thinking to myself, uh, whose phone number is this? It was about 8 o'clock in the morning. So when I answered the phone, the young lady was on the phone and she said, I received a letter from you 2 days ago. And I'm thinking, how did she receive a letter from me 2 days ago? Because I haven't mailed out any letters in about a month. So in talking to her, she finally said to me, I'm homeless. I don't know what to do. I need to talk to someone. So I immediately dropped everything that I was doing in order to help this young lady and to talk with her. So last night, after I left work, I was able to go by her house, and talk to her again. I do the interviews on the phone now, but I do go to their home so that they can sign a consent form. So those are the kinds of parents that I'm dealing with. And this mother said, I'm homeless. I don't know what to do. I have nowhere to live. And so talking to this mother, made me realize that how blessed we are in so many ways and how fortunate we are in so many ways that we have a young lady that actually going from home to home because she doesn't have any place to live. And so I was able to provide her with housing resources when I went to her last night. So I just wanted to share that with you. But in addition to doing the maternal interviews, and I'm not going to waste up a lot of time on that. I know that we're running behind schedule. We also have nurses that go and get the nurse case abstractors, and they do the clinical portion for our case review team. And in the clinical portion, they find out what really happened to that baby. In the maternal interview, I get the firsthand perspective from the parents of what happened to the baby. And if you ever come to one of our case review meetings, you will see that a lot of times what the parent tell me and what the medical record says are two entirely and different stories. And that's okay. That's okay because we can still look at those cases and we can come up with great recommendations for our community action team. So we do the maternal interview to capture information that's not documented in the medical records, to gather information to determine if there were any gaps in services. And once again, we want to hear the story firsthand from the parents. We also want to provide support for the family. Like yesterday, the young lady said, I don't have any place to live. So we were able to give her a list of our housing resources that we have. The main qualification for a maternal interviewer is to be non-judgmental and provide a listening ear for the parent. And that non-judgmental is really important. You can't go into an interview with any kind of judgment in your heart about these parents because you don't know what they're going through in their lives. And there are several topics that we discuss during the maternal interview. We look at preconception health, we look at prenatal care, we look at nutrition, we look at weight gain and health habits, we look at the delivery of the baby. We also look at if there are other children in the home. We look at the demographic information on the mom and the dad, and we look at the living condition for the parents, and also if that mother, when she was pregnant or when she went to the hospital to have that baby, did she have any social support? And a lot of times what we're finding out is that a lot of our mothers do not have a lot of social support. And so when I go in to do the interview with them, a lot of parents are glad that they chose to do the interview, although there are some who said, no, I just don't want to talk about how my baby died. We did talk a little bit about the case abstraction. So we have nurses that look at the clinical records. They also talk to social workers, which include CPS cases, because there are some cases where if a baby died through safe sleep, a lot of those cases are given to CPS, and we have had cases, like I stated before, where we have done homicide, and of course, those cases are given to CPS. The nurse case abstractor also talked to the law enforcement, and they also have an autopsy report if one is deemed necessary. Information from the nurse case abstractor and also from the maternal interviewer. We have case review team meetings. And once again, we do that every third Tuesday and every third Thursday of the month. And when we do these case reviews, what we actually do is we have a tool where we put the cases side by side of what the nurse case abstractor did and what the maternal interview did. And this would give the case review team a look at, oh, this mother said this in this section, but when the nurse case abstractor did it, she said it in that section. So this way we can look at, what really happened, with that mother in the case review team. And so on the case review team, we have very disciplines. We have law enforcement, we have doctors, we have nurses. And prior to the pandemic, we had about 20 people on our case review team, but with the pandemic, and we cannot do our case reviews virtual, so we have to come in-house. So now we have in-house staff where we do our case reviews. And once again, we still have doctors, we still have nurses, we still have social workers on our case review team. Also, I am bringing back in people from the outside now. So there's a nurse from Harper Hospital that comes in, and we also have a fireman that come in, and we have a police officer that come in when he can. So when we look at our recommendations, so we have determined a couple of things from our recommendations. There are a lot of mothers, and Marcia will talk about this a lot, that are obese. And with that obesity, there are recommendations crafted around that these women actually need to talk to a nutritionist or a dietitian. A lot of times those recommendations or referrals are not given to those mothers. And so Marcia will get into that a little bit more. So in fiscal year 2019, 2020, we reviewed 43 cases. 43 cases was reviewed during that fiscal year. And out of those 43 cases, we came up with some things, and some of the things, and I won't go over all of them, was prematurity, unsafe sleep location, none or late entry into prenatal care. And that's a problem for our mothers as well. A lot of them do not go in for early prenatal care. And some of them don't have prenatal care at all. And so there's a problem in our city. So what is it that we need to do? We don't have all the answers, but we're trying to get there. Of the 43 cases reviewed in fiscal year 2019, 2020, we made 63 recommendations. And those 63 recommendations goes to our community action team, which is the Detroit Regional Infant Mortality Reduction Task Force. So I want to share with you a couple of recommendations that we keep making recommendations on. One of them is all women have preconception care available to them regarding pregnancy planning, birth spacing, and just an understanding of why it's important to go to the doctor. And Marcia will talk about that a little bit more. Another recommendation that we continuously doing is wraparound services. We have parents like the lady yesterday that's homeless, and we have parents that need food. We have parents that need transportation, which is another big problem for our parents. And so we want to have wraparound services. We want the social worker to talk about that, the medical officers to talk about that. You know, what is it that the parents really need to help them get to where they are? Also, Marcia will talk about this a little bit more too, is refining the message around marijuana use during pregnancy. We found out that we're finding out that with the legalization of marijuana, a lot of the mothers are smoking during their pregnancy. And so conversations need to be had about, you know, it might be legal, but it's not good for you to smoke while you're pregnant. So right now, I'm going to go through a few slides with you, and then I will turn it over to Marcia. And so I mentioned about present and contributing factors early on, and I'm not going to take time to go over all of the percentages here, but medical mothers present or contributing factors. As you can see, weight is 58%. 58% of our mothers are either overweight or obese, and 51% of our mothers was preterm labor, and 42% had some other kind of infection, and 29% was STI. Next slide, please. So this slide deals with prenatal visit. There was 23% of our participants that went to 1 to 4 visits, 30% had 5 to 10 visits, 11 to 7% had 11 to 20 visits, and that big purple there that says 40% unknown, that's because the nurse case abstractor could not find any information on these mothers. Next slide. So prenatal care. And these are percentages as well. So inappropriate use of the ER was 5%. We have mothers that don't go for prenatal care, but they will go in for the ER. And that's how a lot of times they found out that they're pregnant is through the ER. And also, instead of going to the doctor, they will go back to ER every time they feel like they're in pain or something is going on with them. So once again, the education piece needs to be there. 15% or 16% was missing appointments. So a lot of the mothers, they would schedule appointments, but they would not go for those appointments. And 26% is late entry to prenatal care. That's a large number based on the number of cases that we served during this year. 26% was late entry to prenatal care. So once again, we need to talk about, you know, what's going on with these mothers that they wait so late to get in. And 16% is no prenatal care at all. So mothers' BMI, 12% of our mothers were overweight, 7% was normal, 42% was obese. And the unknown, 26%, once again, the nurse case abstractor could not find any information on the mothers. Next slide. Family planning. So I'll just do one on here, no birth control. And that's 44% of women who do not use birth control. And what we're finding out in our meetings is that a lot of the mothers are telling us, I don't trust birth control. I don't like the way it makes me feel. It makes me gain weight. You know, I don't know what's going to happen to me in the future. You know, some of the same things you hear as to why people don't take the vaccination. I don't know what's in it, is what the parents are telling us. So next slide, please. Substance abuse. Talked about this a little bit. So 44% of our mothers, and we say illicit drug use, but we know that marijuana is legal now, but we still need to have conversations to say, although it's legal, but it's not good for your baby. 23% had history of illicit drug use, current alcohol use 14%, history of alcohol use 30%, current tobacco use is 28%, and 28% for history of tobacco use. 23% was positive drug tests, and 2% was no drug test. So let's talk a little bit about positive drug use. So the positive drug use at 23% were actually when the mother went in to deliver her baby. When she went in to deliver her baby, she had drugs in her system. So once again, we need to start having conversations about what is it that we need to do in order to let our mothers know that they cannot smoke or drink or use drugs during their pregnancy? Next slide, please. Postpartum visit kept. So these are actual numbers of the 43 cases that we serviced during fiscal year 1920. So 15 participants went back for their postpartum appointment. 7% did not go back, and 21% was unknown. So in the maternal interview, we asked them, why didn't you go back for your prenatal postpartum appointment? Most of the answers that I get, because I don't think it was important. You know, I've had babies before. I know what to do to take care of myself. So once again, those conversations need to be had with our mothers early on. Next slide, please. So at this time, I'd like to introduce you to Marcia Clemens. Marcia has been with the Detroit Health Department for just a little over a year. She was actually hired around March or April of last year, right in the middle of COVID. And Marcia will also be receiving her master's in social work next week, actually, a week after next, May 8th. So Marcia, it's in your hands now. Thank you so very much once again for inviting us.
Yeah. Thank you so much. Okay, you can stay here. Yeah. So again, we talked about stages being to support our families and knowing that our families are at different stages in their life, right? So with a new position, being a new mom, some of our moms at this point in time have actually either had another child or sometimes even are pregnant during that particular time. And so what we want to do is pretty much be able to support our families from a trauma-informed lens. And so be able to walk with them through this process of where they are, where do they want to be, and also how can we help them to get there. And so our purpose in general is to basically to provide them with all the different resources that we pretty much have, and also to be able to help them to get ready for that warm handoff to our behavioral health team, depending on some of the things that comes up in our actual survey. And so in our survey, we do discuss nutrition, chronic diseases, coping skills, and also self-advocacy, because that is a huge one. That just encompasses everything that we do, even though during our third session, we kind of hone in on it just a little bit more. And so also within our four sessions, their design is really based off of the recommendations that we kind of get from our case review team. Next slide, please. So this is actually our first thing that we kind of do. So we either mail these or Mildred sends them out to our families. So this is a survey. And so I'll kind of just go over just a couple questions because you probably can't see it. So we talk about, again, healthy eating, talk about coping strategies, and being able, based off of those actual questions, we'll be able to see whether or not we can refer them out to our behavioral health team at the beginning. And so what we pretty much end up doing is tag teaming with them through that actual process. So you can go to the next slide. And so through our session one, we do an overview of the survey. And so we'll be able to just dig a little bit deeper into what it is that the client needs at that particular moment. Because even though during our stages curriculum, it talks about a plethora of different things, but we really want to get it from a client-centered perspective. So we really want to know, well, where are you right now? And what is it that you need at this particular moment? And what I love about this particular curriculum is that we incorporated the journey, so guiding your steps with growth and change. And so this kind of thing talks a little bit more about the different areas, such as discussing previous challenges, successes, identifying supportive people, looking at mindfulness. And so trying to have a wholesome perspective when we're actually walking this through with our participants. And so this is actually something that we end with every session, and then we actually bring that back. So we are pretty much going through this pretty like either once a week or once a month. We're going to, depending on the participants and what they're comfortable with. So with that, we end with it, and then we also begin with that. So just checking in again, just figuring out where they are. So, and then what I love about this is that the next step, so you can keep it there. So our next steps, we really help them to, well, what can we do right now to help them to move to taking those steps, and it looks at what's needed, what they're excited about. So it's kind of like the concepts of the SMART goals. So within our session 2, it looks like it's a lot because our sessions are about an hour to an hour and a half. But again, we want to definitely start on stress because especially with looking at COVID, how COVID has affected our families. So we look at stress first, and then we kind of go into the different other areas. And so we do also do some journaling with them to be able to just talk about, well, what is it that that they're actually dealing with. And so when we're looking at, right, alcohol or tobacco use with some of our families, as you guys saw the stats earlier, we're also looking at that. That was actually a coping mechanism that they were using to actually deal with their stress. So so that's why we kind of go through and talk about some of the coping skills. And then again, we kind of hit on the different, maybe some of the different diseases that they were, that was showing up. And a lot of times, many of them was high blood pressure, iron deficiency, and also diabetes. And then going into, again, with the physical activity. So pretty much honing in on just a lot of information talking about looking at a healthy weight, and then looking at, and my thing is this, we don't want to just throw information at them, but we want to meet them where they are. So dealing with nutrition in itself, well, what is it that you are doing right now? And how can we incorporate some things? So you can go next slide. And so within our third session, we, yes, discuss the doctor visits, because as Mildred stated before, we are noticing that they are not going to the doctor, or they're late entry, which is about, I think, after 12 weeks, if I'm not mistaken. So talking a lot about that, and also within 10 reasons why to go. And then we also even bring in the fathers of being also checked out too. And then we talk about a lot of the myths and taboos of why they don't go to a doctor, or even talking about contraceptives. And so we kind of go through that whole list of just the different contraceptives that we actually have out here, and try to just discuss more so more information. Self-advocacy is a huge thing just overall, because a lot of our families, they don't necessarily know what to say. And so they're kind of just depending on whatever the provider is stating to them, without questioning or without challenging that individual at all. And so what we ended up doing was incorporating a checklist of questions to ask our healthcare providers to be able to build on that self-advocacy. So you can go to the next slide. And so within all of our 3 sessions with our families, towards the end, as I said it before, going through that journey, right, that they're kind of listing, we come to a conclusion and we discuss, well, again, what is it that you really want to focus on? And so that's kind of like through our resources. So even as we're going through these different sessions, we're providing them with resources, we're checking in on them. So it's not that we're just giving this to them, but we are making sure that they're following through with that. And so for our last session, we actually give them a vision board. You know, we're looking to actually give them also journals to help with just being able to write out the things that they want to do, to get out their emotions. And so after that, after we kind of discuss this with them, and then so you can kind of go to the next slide. So we actually also give them memory boxes. And so I want to have Mildred to kind of just talk about what's in them. And so you can go ahead, Mildred.
Okay, thank you, Marcia. So yeah, each parent that we do a maternal interview with.
Excuse me, Mildred.
Uh-huh.
We're running out of time. Can you?
I will.
You to wrap it up, but we need to move on.
Okay. So in the memory box, just 2 minutes, we have a poem in the memory box, which entitled We Miss You. And each poem, the child's name is on that. We put a rose, a candle, a teddy bear, blue or pink, depending on if it's a girl or boy. We also give the parents a journal, like Marcia stated, and we give them a cup. And so all 24 participants, once again, will receive a memory box, and 10 of the 24 participants will receive our stages presentation. So thank you so very much. I do want Marcia, just for a minute, just to talk about our resources.
Before you start, Marcia, this list of resources will be shared with you all.
Okay.
So you will get this in writing. And this is really, really appreciated because this is something that we've been asking for. So, Marcia.
Yeah, so these are our resources. And so I really do want to hone in on a lot of we do provide a lot of different things with our Detroit Health Department. And also we even added the infant mental health programs because those are definitely some things that we want to give out to our moms if they're looking to just like as far as like the process, and also being able to just discuss things as far as if they're looking to actually do some more like family planning. So this is just a little bit there. And then we also have our grief and loss. And we're actually, again, we're expanding on this. So this is not just this is only the beginning of it. So I'll definitely look forward to also just updating you all on our resources too. So thank you all for having us.
Okay, well, thank you, both of you ladies. Again, this is something that we really have been looking forward to hearing about. And you are part of our team, so we hope to see you participating in more of our meetings so we can keep the connection going. So thank you. We really are behind time, but everybody's doing such a great job. I have no apologies, but we want to get you out as close to 3 o'clock as possible. So being flexible, what we decided to do is to just give you a brief overview of what we were going to do in the equity discussion and still have you give some thought to that. So introducing Karen Schrock from our team to kind of pique your thoughts. Thank you, Karen.
Thank you. First of all, this is Minority Health Month. And when our team talked about putting this program together, we thought it would be important to remind everyone of that and to focus some attention on the fact that we have a very diverse region. And it's important for us to acknowledge all of the grief we've heard about today, and then pay attention to the implications of that diversity. So we've heard about infant mortality, maternal mortality, COVID, racism, and a lot of other community problems. And the idea of this issue is to think about grief and how it's affected by the unique cultural aspects of people in our community, and how is grieving different amongst different groups in the community. We saw a front page article back at the end of March where they talked about how mental health is strained by grief. And so we wanted to know how many of us are really paying attention to the mental health of the people that we're serving. We're talking about losses today, infant mortality, maternal mortality, but we wanted to say we're losing a lot of people in this community through COVID and all the other normal ways that we experience losses. So that is the focus that we want you to go back and address with your teams. We want you to go back and talk about, we know we've got a pandemic, but the cultural implications of grieving are important for us to acknowledge, to respect, and to honor. And so whether it's Native American culture, African American, Jewish, whatever culture you're dealing with, we want you to just spend time around your table discussing it. And we'll probably have an opportunity to do a more thorough presentation and discussion of this later. So just as you go back, think about grieving and how it's different amongst all those very rich cultures that we have in Region 10. Thank you.
Okay, thank you, Karen. There's probably not a person on this call that has not had a loss, say within the last 24 months. And if you think about your own grief, think about the grief of those we serve and how we can, be more responsive, be more humble, be more understanding. And somewhere in the presentation, I think it was Mildred, that said, and listen. So moving on from that, sorry we didn't have the time to have individual discussion, but I think you get the point. We are having our first public screening of Toxic, a Black Woman's Story. And I'm going to introduce Dana Harvey, who's marketing this for us and doing the communications. Dana?
Good afternoon, everybody. I'll make this quick because I know that we are short on time. But I believe that many of you are familiar with and or have seen this film. At this point, I am working to assist SEMPQIC with sharing this to the public at large. So it is scheduled, the screening that we're hosting is scheduled for next Thursday, May 6th at 6:30 p.m. And essentially we are targeting, women of childbearing ages, their parents, their partners, service providers, support care services, child care providers, essentially the public at large outside of the coalition who needs to be made aware of this issue and how SEMPQIC and the rest of the coalition is working to eradicate these healthcare disparities as it relates to women of childbearing age. So we will definitely make sure that this information goes out to you. We would appreciate you sharing it with your networks. I believe we will get a flyer as well as the copy out for you. So the screening will occur again at 6:30 p.m. starting, and then we'll follow the screening with the post discussion with panelists that include Vern, Dr. Monica Lee Griffith, and Robina Hills. She's a doula and a home visitor, and I will be moderating the discussion. So please encourage your networks to attend. Please have them register as soon as possible. And if you can just share it wide and far, we would really appreciate it.
Okay, thank you, Dana. And again, please share. We're not focusing on healthcare professionals, really the public at large, especially Black women and people who care about them, which really should be everybody. Thank you. Okay, moving on, saving the best for last. You guys hopefully you saw the press release or the announcement last week from GDAC and MPHI on the marriage, the integration of GDAC into MPHI. And we also sent out notice from SEMPQIC. This change will be actually transparent to you because all of our team is staying in place and we're just moving forward. And we appreciate the work that Kate has done to bring us to this point. Thank you, Kate. And we appreciate MPHI. We all know Renee, of course, from all of her work on equity and public health for years. So with that, I will pass it to these two ladies to give you an update. And we're very excited.
Thank you, Vern. I'm actually going to defer it to Kate to begin. We didn't really discuss order. So Kate, do you want to proceed and I'll follow up?
We have been working on this for many, many months. Many months. Sometimes it felt like it was never going to come to fruition, but this is GDAC approached MPHI several months ago and raised the conversation about a partnership. We were looking to ensure the long-term viability of our organization, which really was hit hard from COVID. And COVID has really just changed the whole landscape. and being the leaders that we have been for a very long time and forging new models and being able to evolve seamlessly to the healthcare landscape, this made sense for us. So I reached out to Renee, and at the time, before we called her, we stepped back and said, well, if you were Renee and somebody was going to call you and say, what about a partnership? She might say, well, what's in it for me? So we had actually said, well, we have this presence in Detroit that MPHI doesn't have, although they do work in Detroit. And we have this broad network, and we have this community that we're so pleased to serve, and we have very similar missions and visions. And so when I reached out to Renee, it was something like, and I'm going to really paraphrase this here big time, but wow, this is the answer to my prayers. I've been looking for a partnership in Detroit. I've been thinking about a partnership in Detroit. We definitely want to have a presence there. It's something we've been discussing for a very long time. In addition, we've been looking at how we can work a little more closely with the hospitals and the providers. And you're checking those boxes. So right off the bat, it was a marriage, so to speak, made in heaven. And so we went from there, and it hasn't been easy, smooth sailing all the time. There's obviously, as you can expect, a lot of legal hurdles and challenges, and but we were both organizations very committed to making this happen, because we know it's the best thing for the community, it's the best thing for our partners, and it's the best thing for our staffs. And it allows both organizations to move forward without competing for limited resources, without competing on vital grants. One of the things that we learned recently, one of the big grants that we just received was down to the wire between GDAC and MPHI. And so now we're not competing in that space anymore, but actually being partners and taking this to the next level. So unanimous, unequivocal support from the GDAC board, and I am so excited to be out of the shadows and to be public with this work. And thank you, Renee, for everything you've done, and Vern as well for all your support as we've gone through this process. Renee, I'll turn this over to you.
I agree full-heartedly with Kate's points, and sometimes need and opportunity just happened to bump into each other on the corner, and it was a bi-directional need and a bi-directional opportunity. And so I'm thrilled. I mean, I had really just sort of painted myself in a little bit of a corner with my board, and I said, I commit to strengthen our relationships with health systems. And then I went back to all my public health staff and said, now how are we gonna how are we gonna make friends with health systems? I've already said they're gonna be evaluating me on this. And so I am grateful that prayerfully this opportunity came together. We had been asked by a number of our funders, two of our funders precisely, would we consider a greater presence in Detroit, not in terms of, you all know, we're sort of behind the scenes working with you to promote health, but would we consider a presence so that partners in Detroit could have easier access to us? And so we were certainly trying to think through that pre-COVID, and now being very intentional about what that looks like when we're all back in an office space. So I am grateful for the 77 years of contributions of GDAC, and really honored that we'll be able to be a critical part of that legacy. I will share with you that this morning when I was meeting with our HR leader, Heather White, we were talking about the position description that would serve sort of Kate's role. The rest of the staff, as she mentioned, will be seamlessly transitioning, being a part of our payroll. We're hoping to make this value added, and not like, I don't think there's going to be some culture shock, because both of our cultures are very similar. And so when we get that senior leader position description finalized and start posting it, I hope that you all will be instrumental in helping me identify the right leader to serve that role with the health systems, and some of the many things that Kate has carried out in supporting her team. And also just pave the next wave. How can we bring all of those MPHI resources and infrastructure to strengthen the work that is being led by you. So thank you guys for the messages that are coming through chat, congratulating us. And we're excited to kick this off. All of the little details will be done in May, but staff will be transitioning over will be done in December, but staff will be transitioning over and getting their paycheck from MPHI starting in May.
Yep, so
Okay,
we're so excited. Thank you again.
Yeah, are there any questions or comments from any of the other SEMPQIC leadership?
This is
I, for
Alicia.
one,
We're
have-
excited too. We're excited for the partnership as well, and look forward to working together because we've been working together right along anyway. So it's it's really good to make it formal.
Okay.
We're always here to answer questions as well. If anybody has them, just feel free to reach out.
Kadada asked, how will this impact SEMPQIC? Well, actually, the work that we're doing now is going to continue. As you know, and you certainly know, Kadada, that we are so closely working with our funders. All of our funders actually have agreed and are very excited and support the transition. We've met with Merck, we've met with Kellogg, and of course the state is very excited about the transition in terms of the administrative support for that MPHI is going to bring. Everybody recognizes that almost all nonprofits, this is a good time to re-examine your sustainability. We're losing way too much as a result of COVID. And we think the focus should be on the mission, not the organization. So we're really pleased to have a strong future for the mission of GDAC. And you know that SEMPQIC is one of 10 regional perinatal quality initiatives around the state. So that's not going to change. Dawn and the state has been very helpful in making this transition work. And I would say that Region 10, we're not only the largest, but we're the most impactful in a positive way. Regional quality coalition in the state, and we intend to stay that way. So
I will add
more and better.
One thing that I will add is, we describe ourselves at MPHI as a team of teams. So some of you probably know others of our team leaders, Julia Heaney and Jen Torres. And I try very much as a leader to lead from a servant leadership perspective. And so Lisa Braddock's leadership with SEMPQIC will continue to be SEMPQIC's leadership. And so consider us an extra resource. We're going to make sure that Lisa has everything she needs. And if she needs some other things, then we're going to make sure she has those things added. We really are trying to not be disruptive, but enhancement. And so I agree that SEMPQIC is absolutely one of the most effective collaboratives. I hope that my closer connection will help some of the other collaboratives to take lessons and take notes from what SEMPQIC's been accomplishing.
So, and if I might just add quickly too, I appreciate your comments, Vern, about the mission being what's really important. Some of you may have seen the article that was in Cranes about this merger, and they really focused more on the dissolution of GDAC. It doesn't matter what legal form we're under. It really doesn't matter. What matters is that we're continuing the work, that we're a solid entity, and that the mission continues. And that's really what this is all about.
Lisa, do you have any comments you want to share?
Really, I think that, I'm appreciating all of the positive congratulatory comments on what has just been announced. And I certainly agree that this is a positive step forward. And I'm very much looking forward to really continuing to do the work. Now as a part of MPHI and with that additional support and additional team to add to all of the good things that we're already doing. And so I just see us really taking off with this and really looking forward to continuing the trend that we talked about at the beginning of this meeting, with the numbers coming down for infant mortality. So I'm excited, and I'm looking forward to it.
Okay, well, in the meantime, please feel free to add any more questions to the chat, or, you know, Kate's phone, I was gonna say door is open, but the phone is open. And email, as is Renee. So if you really have any questions or anything else, quick reminder, the toxic screening is May the 6th, and we did put on the agenda where you can sign in or register. It is free. And if you haven't seen it, please do register, and again, share it on your social media. And is today your birthday, Kate?
Yes, today is my
I
birthday.
see that. Happy birthday. If I could really sing. Happy birthday, Kate. Thank you.
Thank you. Thank you. And I really am in Florida. So
Yeah.
that background's a little exaggerated, but I really am somewhere different than my office in Detroit or my home.
Thank you. Well, enjoy your birthday. Are there any other announcements from anybody still on the Zoom that's going on in your agencies that you want to share? Okay, if not, thank you, everybody. And you'll be getting all the slides that were shared today. We'll be going over the chat and answering any questions. So enjoy the rest of this. Yes.
Vern, one last thing. I see that Devin put up the evaluation, so maybe people
reminded me of
do
that.
the evaluation before they check out.
Yes, please do the evaluation before you check out. Thanks, Karen, for reminding us. And enjoy the rest of this beautiful day. I certainly am. Okay.
Bye, everyone.
Bye.
Thank you.
Bye.